This is a nice case that demonstrates the removal of a Tecnis multifocal lens and replacing it with an accommodating Crystalens. I had done the original surgery on this patient about 6 weeks, maybe 7 weeks prior to removal of the lens. We had a nice result. She was 20/20 and reading well with this lens on day 1 and week 1, and she continued to do that. However, she was truly bothered by driving at night. She just could not drive at night, and she did not want to give that up. She wanted the lens removed right away. We said, let's leave it, and we went on to do a Crystalens in her fellow eye, and she wound up with an excellent result in that eye and was reading well and having good distance vision. Asked us if we would go ahead and remove the Tecnis multifocal. So what we're doing here is we made a couple of entry sites, and we're using viscoelastic to free up the capsular envelope to try to break any adhesions between the IOL that have formed during the healing process. We're using a cyclodialysis spatula here. In the beginning we used the viscoelastic cannula. It's a really good idea to take the viscoelastic cannula right over the haptic in these acrylic lenses like the Tecnis and the Restore, and actually use it to dissect the haptic free. It's especially important in the Alcon lens because of the bulbous extension on that lens that makes it really adhere to the capsule and makes it a lot more difficult to remove than in the case of the Tecnis lens. But you can see this lens is beautifully centered. It was an excellent case. Unfortunately, she was one of the few patients in our combos where we've combined a multifocal with an accommodating lens who could not tolerate the multifocality. And we could have left her for 9 or 10 months, but that's not kind to do to a patient, and she really was unhappy. And she was very happy with the Crystalens in the fellow eye. So here we've got the lens up. We're coaxing the haptic out of the capsular bag, and because we're going to replace the lens with an accommodating lens, we're going to enlarge slightly to allow for that placement, and then we go in with a Sinskey hook inverted, and we come underneath the haptic that we have close to the wound, and we pull the haptic through the wound and have the haptic outside. At this point we use two 0.12 forceps. We hold with one, and the second one we come in and actually impale the about a third the way or halfway down into the lens, and just gently move the lens through the incision site. Here we're putting viscoelastic in to reform the bag. Because we want this to be as close to a virgin capsule as possible, I'm putting a tension ring in. The capsular tension ring is just a wonderful tool when you're using any of these premium lenses and you think there may be some issue where the capsule or the capsular support system, the zonular support system, is compromised. So you can see that the bag looks nice and taut following the CTR. Now we're placing the Crystalens in the bag, and with the Crystal inserter and a little patience, it's quite easy to place the lens in the capsular bag almost every time in a single maneuver. Here I'm rotating the lens. We like to leave these lenses in the vertical position, and so we're simply doing that. Once the lens is in position, using this modified Sinskey hook, we seat the lens properly, and then to ensure wound integrity during that first 24 hours, which is kind of important with a Crystalens because you don't want an early vault, we place a 10-0 nylon suture. This was suggested by Stuart Cumming when the lens first was introduced. We got away from it, and I've been convinced by my friend John Hovnasian that it's probably important to do this because of the possibility of a micro leak from the wound. So here we're removing the viscoelastic. It's good to get as much of the viscoelastic out as possible. I usually go beneath the lens to remove viscoelastic, but I don't always do that. I think it's good to do if you're comfortable. I just didn't want to stress the zonules anymore in this case, so we decided to come out, and here we're pressuring the globe The anterior chamber you want it to be formed so that when you tie the suture, you're not inducing any unwanted astigmatism. So with the anterior segment, the way I'd like it in terms of pressure, we go and we place the 10 nylon suture, rotate it into the wound, and here you see a nice result. Pressure's good, the lens is well centered, and this patient went on to have an excellent result. She was basically 20/20 in this eye the next day. Very happy with the absence of the multifocality, and that's just a nice way to end an issue for a patient like that.